Hey everyone, I'll go ahead and start the critical appraisal of a randomized control trial using the CAST and parts of the Consort AI checklist. So we look at a scenario where our medical superintendent is considering integrating this tool, Echo Go Pro, which is an AI decision-making tool in the echocardiography referral pathway. So referral pathway in the sense, when you do a stress echocardiography, which of these patients are you going to refer for an invasive coronary angio or to the cardiologist? So now we want to know whether implementation of this Echo Go Pro in our decision making about referral, will it improve appropriateness of the referral? Like the correct patients who actually have coronary artery disease are getting referred. And does this work at a high volume center like ours? So this is the trial we're looking at. This is called Proteus. It is a prospective randomized control trial evaluating use of AI in stress echocardiography. The title itself doesn't tell us much more, but we'll come to that. And I'm using the Consort AI extension to the Consort checklist, which Sir mentioned. This was published, I think, in 2020, and the CAST checklist, which we are all familiar with, and this is freely available. Both of these are freely available. So the first section, the format I'm using is I will go through the CAST checklist as we usually do, and I'm adding parts of the Consort table wherever it kind of matches the CAST question. And I will highlight mainly the AI questions and the additional extension that has been added to the original Consort checklist. So the background here is stress echo, as we know, is a non-invasive tool to identify coronary artery disease, assess the severity, select management approach, and it depends on visual quantitative assessment of the image. You look at the image and you decide. Now, what is AI? What is the role of AI in cardiovascular imaging? It helps in acquiring good images, quantification, like some measurements can be done, and disease assessment. But does this impact patient care outcomes is what the authors wanted to look at. So the first CAST question here comes is, did the study address a clearly formulated research question? And the corresponding Consort checklist questions are these, which is about the, I think I'm missing a table on the introduction and the scientific background. This part also asks us to explain the intended use of AI intervention. What exactly are we going to do with the AI? So the author stated, what are we going to do with the AI in this pathway? So if you look at the PICO statement, the population here is adults undergoing stress echo. Intervention is AI augmented decision making. So it is not AI alone that is making the decisions. If you integrate AI into your decision making pathway, does it change patient outcomes? Comparative is standard clinical decision making. What was normally happening to these patients undergoing stress echo? Outcome is appropriate referral for coronary angio. And how do they say appropriate? So true positive is somebody who is referred for angio and requires revascularization. So that is like a true positive. And a false negative is you didn't refer them for angio, and in the next 6 months they had an MI. So you went through this pathway. You said that okay, you don't need angio. I won't refer you for angio, but this person has an ACI. So that's like your decision making failure. And the time period we only followed up for 6 months. I think I skipped the slide. So this is again the title and abstract of the study, again from the Consort checklist. I'll go back here. So the Consort AI asks whether the authors included that they're going to use AI in the title. It should be clear from the title that they're going to use AI, and they should tell you what model it is. So we looked at the title earlier, and it just tells us that there is evaluating use of AI in stress sector. The next question is, what is the intended use of AI? So they don't say it in the title, but they give it in the abstract. We already spoke about this. So AI augmented decision making. Here they're trying to look at whether it is non-inferior to standard decision making. Secondary outcomes that they looked at are, so one thing was non-inferiority. They took superiority as a secondary outcome. Correct management decision, so to say. Referral pathway in the sense, did the patient require any additional testing? And patient reported quality of life outcome. So there is the Seattle Angina questionnaire and EQ5D questionnaire. These are secondary outcomes. The next part of the Consort checklist, it talks about the trial design and the participant eligibility, inclusion and exclusion. So the trial design was a multi-center trial in the UK, and they took several sites, which were all NHS centers. So it was a multi-center parallel group RCT with a 1:1 allocation to the both intervention and control arm. And the Consort checklist asked if there were any changes to the method of trial design. So the answer for that is no. The special questions for AI is when we come to participant. One is the inclusion and exclusion criteria at level of participant, and the next is inclusion and exclusion criteria at the level of input data. Other thing is about the setting and how the AI was included in the at the site, and how did it physically work? What were the logistics of that? So I will go into that. So inclusion criteria for participants were adults who were referred for stress echo in a UK NHS center, which is part of the trial. And the intention was to investigate for ischemic heart disease. Now, they have mentioned inclusion criteria for data input in the published protocol, but not in this trial itself. So stress echocardiogram are eligible for going through the AI device only if they contain the required views for the peak and rest images. So you need to have an apical 2-chamber and 4-chamber view, as well as a parasternal short axis mid-ventricle view, and has to pass quality assessment. So only an image taken in stress echo would only go for AI assessment if it fulfilled these criteria. So this we need to keep in mind. They have not given any exclusion criteria, but I guess this is it. For patient level exclusion criteria, if they had a valvular heart disease more than moderate severity, left ventricular outlet obstruction with a gradient of more than 30 millimeters of mercury, significant comorbidities, example cancer, and when the investigators predicted that the patient would die within the next year, they excluded this group of patients. So very sick patients, not part of this trial. The patient has already undergone bypass or any other cardiac surgery, and if they have congenital or inherited myocardial disease, so these patients are not part of our trial. So how was AI integrated into the trial setting? So the stress echo images were sent for assessment via VPN. So the trial center had connection to a VPN. Through this, the images were sent to the AI. There was a quality control check there. They have not said whether the quality control is done by the AI or if there is any human involvement in that. I couldn't make that out from the protocol either. Then the AI does contouring of the images and it classifies. It classifies as either high probability of CAD or low probability of CAD. This threshold is based on previous trials they have done with the Echo GoPro, where they used retrospective data and they have seen that, okay, they have certain parameters based on which there is a high probability, less probability. And then the AI gives a binary report, yes or no, high probability. And then only this report is sent to the clinician, nothing else. It will just say high probability of CAD, low probability of CAD, back to the clinician who actually read the stress echo and is looking at the report. Yes.
Normally, the stress echo images go to the initial review. That is the standard.
Yes.
And the clinician has clinical data. The patient. Yes. Here, the AI does only looks at the images, but only looks at the images and tells you whether it is positive or negative. Instead of the clinician reading, the stress echo. Yeah. Actually, clinician can also read the stress echo. If nobody is stopping them from reading the stress echo, this is giving an additional input.
So this is the diagram that they have given in their supplement, where these are the stress echo studies. They have a cardiology packs, and patient is randomized here before the images are sent. So the black hexagon here is the intervention, and the white one is control. Here they have given good information about how they have encrypted the personal data before sending it to the AI company. So they have anonymized the patient data, only the images go to the AI, and the intervention images are only supposed to go to AI. Then they come back, and then it gives the result back to the clinician. So this here it says that intervention arm result returned immediately. They have said that it takes around 20 minutes for the result to come back to the clinician. So the next part of the Consort AI checklist asks which version of the AI algorithm was used, how the input data was acquired, which we already looked at, what did they do with poor quality data, whether there was any human AI interaction analysis after this, what was the output, we looked at if we give output as high or low probability of coronary artery disease, and how this output contributed to decision making in times. So they use the Echo Pro version 1.0, 1.0.6. They don't give us anything else. It's a patented tool. So they're not going to, it's a proprietary thing. So they're not going to share the details of the model, but they have told us which version they use. So they said that if the images do not meet requirements for processing, a rejection report was generated. And feedback was given back to the person doing the stress echo that, okay, you need to improve your quality of images. And they would go and give feedback to the center if required during the course of the study if the image quality was poor. And in fact, towards the end, we'll notice that a lot of the images were of poor quality, and even the intervention arm, we didn't have an AI result. AI report to augment decision making. Then the study images were uploaded through VPN. We don't know how much human interaction was there. The output I told you, the high and low probability. And so the patients, after this decision, were continued their care pathways based on the management clinician. So this added to their routine standard of care. So they have an algorithm which they follow for anybody who has angina, and they will follow that. Only additional thing is this result. So the intervention does not guide or dictate any of the other management pathways. Only gives this information. This is the other questions of in the consort checklist of what were the outcomes and what was the sample size, and I'll come to the corresponding CAST question. So the outcomes are appropriate referral of participant for coronary angio following stress echo and follow-up of 6 months. So true positive, you referred a patient for angio, patient required, yes.
One question they mentioned how many infusions were in.
They don't. They say sometimes they say the managing team. They sometimes they say the practice. Say it's not.
Multi-centers must be multiple clinicians. And may come any time of the day. It will be post and issues and you can must be multiple clinicians multiple times.
So there is a decision making factor.
It works both ways. If it is a group, why you take the from junior to senior cardiologist all over and still works, and you say that in a heterogeneous population of cardiologists it works. On the other hand, you say it's not which cardiologist is it? Something they say you should have taken all senior cardiologists, but then they won't be there all single point of time. So they have taken a break.
What I understood from what they've written is that the primary physician who has ordered the stress and is looking at the and is going to decide on referral gets the result of the, and I will come to blinding as to who has that information and doesn't. So true positive we spoke about. False positive is so there was an error in the text, which is why I just put this strike through and mentioned that they've written this true negative, but I think it meant false positive. No coronary artery disease in referred patients. So this is the false positive. So you thought you need to refer, but the patient doesn't have coronary artery disease. False negative is you didn't refer, patient has an MI. And true negative is you didn't refer, the patient is well for 6 months. So 6 months is maybe not a long enough time to see the outcome of stable coronary artery disease. The sample size calculation, which is part of our the consort asked for. So they have gone with the area under curve. So whether a clinician doing a routine stress echocardiography has a discriminatory power, like how well are they able to distinguish person with or without coronary artery disease, and they expected that this would be 0.88. And they expected that intervention would add to this AUC by 0.07 based on the, so they did a priori sensitivity analysis, which they have published in their previous protocol. Okay, if we are expecting this much of a difference, what will be my sample size? If I'm expecting this much of a increase in the AUROC, what will be my sample size? And they went with this. Though since AUC is not a very clinical outcome, I'm okay with them using the mathematical tools, but otherwise I would want to know what is meaningful. So in terms of AUC, I find it difficult to say what is meaningful improvement in AUC. They expected that there would be 122 positives, so in the control arm, and based on this, they calculated that 1,534 participants would have an 80% power to demonstrate non-inferiority to one-sided alpha error of 0.05. This was the primary outcome. Secondary outcome was superiority, and for that they calculated that they would require 2,132 patients. So they plan to recruit 2,500 in order to have enough power to demonstrate both non-inferiority and superiority. They have pre-specified an interim analysis at 3 months, and it eventually didn't lead to any change in their sample size. But they have not changed their significance levels based on this in their pre-published protocol. Also, they said that we will do the interim analysis, but we are not going to change our significance level, which maybe they should have. They should have decreased the alpha if they were going to do yes.
Basically, clinician was not augmented by this. He says do the angio. Yeah. And the AI augmented clinician says do the angio. That will be concurrent, and it will they do a coronary and they do a coronary angio. In this outcome, both of them will get a coronary angio, right?
Yes. So we are going to look at so this is referred and has coronary artery disease. Doesn't matter whether it was intervention arm or control arm. This is just the classification of outcome.
All these people have had an angiogram.
No. These are, so patient has stress echo. Then based on the stress echo result, you decide whether the patient gets angio or not. Whether you refer for angio or not. True positive would be anybody who is referred and requires stenting. So that is true positive. This is the outcome. This can be either in the intervention arm or in the control arm. The referral could have been done by somebody who has the AI added information or doesn't have the added.
Yeah.
So either. This is just classification of, and we're defining the outcome here. What is outcome?
So for the people that did not require an angio, either
Not referred, yes.
they just follow them up for 6 months to see whether
Yes,
they get
yes, yes. Yes.
This is superior versus non-inferior. If they give a percentage as in these many people who had, angiogram positive coronary artery disease with the help of the AI. So let's say this much percentage of people had a true positive over just the clinician. So should they give that sort of?
That's what I think. Sensitivity, that first line, area under the curve is a combination of sensitivity and false positive. And area under the curve of 1 means 0 false positive, 100% sensitive, everything is truly disease, and people who have no disease have no disease. So they say without the area itself, the stress echo itself has got a very good discriminatory factor of 0.2. 88% of time when it says disease, it is disease, no disease, it is no disease. The added benefit is going to be another 0.7, so it's going to 0.95. You may argue that that's not a clinically meaningful difference, but they have taken that as the area is a combination of both sensitivity and false positive. So that's what they've taken as a margin for instance.
I didn't put up the AUC statistics because it got a bit complicated. So the next question, so first was what is the study design, what are the outcomes, are they well defined? The next part is whether the study was methodologically sound. So the second question here that comes is whether the assignment of participants to intervention was randomized. How was the randomization carried out? Was it sufficient? Was the randomization sufficient? And was it the allocation was concealed from the investigators and participants? And the corresponding consort questions are about sequence generation, allocation concealment, and the implementation. I won't go into each of those specifically. So randomization and allocation concealment was done in a 1:1 ratio via an integrated web-based platform. They've given the name also. This is the Castor electronic data capture. And it was a stratified randomization. So based on sex, recruiting center, and pre-existing coronary artery disease in a random block design. So blocks of varying sizes. Randomization, allocation sequence, and blocking parameters were defined by an independent statistician, and implementation of allocation. So actually recruiting the patients and allocating them to an arm was done by a different person who was a data manager. Yes. It is a non, the primary outcome is non.
No, that's the trick of doing an RCT nowadays. You start off saying non-inferior. So you calculate a sample size. But a non-inferiority trial can also conclude superiority equivalence. It can also conclude superiority. So you can calculate 3 sample sizes and you take the largest sample size. So the end of the trial, you can easily, comfortably conclude non-inferiority. You have enough sample size to conclude equivalence. You have enough sample size to conclude superiority. So you can give all 3 sample sizes. So at the very least, you can conclude non-inferiority.
And when the outcome that you're looking at is not time based, it's not like okay, we'll hasten the decision making. It's actually looking at hard outcome of the event. In that case, when you already have years of APA, inferiority is really not an acceptable situation, right?
So that's the thing. Everybody now wants to start off. The advantage of starting with this. The disadvantage of superiority trial is if you don't disprove, then what do you say? The null hypothesis is true. We can't conclude that. We can just conclude that the new thing is not superior. If it's equal to the previous group, we can't see equivalence. If it's worse, we can't say non-inferiority. That's the structure of the superiority. So if you want to conclude non-inferiority, equivalence, or even inferiority, you have to start with the non-inferior design. From there, you can go to any outcome or down. Some of that design helps in that. So everybody now likes to start with non-inferiority. The trick in non-inferiority is very important. You are saying a drug is going to be inferior to the, slightly inferior to the current standard. Correct. That's not inferior or slightly inferior. So I don't need, I'm not trying to prove superiority. So that's called a one-sided alpha. I'm only looking for slightly worse. The real logic of an RCT is equipoise. We start off not knowing whether the drug works or doesn't work. The drug may be better, the drug may be worse. So I must have enough sample size to look for slightly worse or slightly better. So all when we do sample size calculation, they'll write that two-sided alpha. I mean the sample is enough for superiority and inferiority. Many people take non-inferiority trial and say I do only one-sided alpha because I know my drug is not going to be superior. So they get half the sample size as a superiority trial. So if you find a non-inferiority trial or somebody purposely did half sample size to save on time and money and effort, that's wrong. Currently, they've got two-sided alpha, or they should take double the sample size, even if they're doing a non-inferiority trial. Especially if they say that in the same trial, and we also look for equivalence, and we also look for superiority. So basically, trick is this non-inferior design. Many people choose it because then they can make some reasonable conclusion at the end of the day. You start with superiority, you're only left saying it's not superior. Okay, is it equivalent? No, I can't say. Is it inferior? I can't say. So it's really, so now non-inferiority is a good thing to do.
And guessing if they had been able to achieve non-inferiority, they would have said, oh, this will save time or some other advantage of the intervention which they would have tried to say. Sorry? So secondary outcome is superiority. But they've mentioned one-sided alphas.
These are the things we must pick up. Hey, where did you put one-sided alpha? Then the difference you say 0.05. They said, no, we took 0.025, half of that. The alpha error will half the alpha error. That's why we don't put two-sided alpha. But we should not do all this. Ultimately, they all try to save what happens.
Okay. Taken 0.05, yeah. So next question is whether the participants who entered the study were accounted for at its conclusion. It's talking about loss to follow-up and exclusion after randomization, whether they have given a detail of that, whether they were analyzed in the same group, whether they did an intention to treat analysis, and if the study was stopped early. So, and these are the corresponding questions from the Consort checklist. Participant flow and numbers analyzed are not, these questions come a little later for recruitment and baseline data. So this is the Consort figure. They have a population of 4,907. So these are patients who are planned for the stress echo in all the NHS centers that were part of the trial. And what did they do? So they looked at medical records to see who are the eligible participants, and they contacted them saying that you need to come for a trial and they're planning to do a study. Might you be interested? And they verbal, email, and telephonic consents. So out of around 5,000 population, they already screened out based on review of records, some 263 of them. And then 4,644 were left. And then they contacted this 4,600. Again, they screened and removed. I'll go to the next slide, so it's a little better to see. Here. So 500 or so declined. 750 were excluded because of non-eligibility for the trial. Then there is other exclusion, which is again more than 500, and unknown exclusion. So like almost 1,000 patients were excluded for unclear reasons. And we ended up with 2,341. If we just go back and recall our sample size, so they would have required 2,132 to demonstrate superiority. And they had planned for 2,500 accounting for dropout. So 2,341 underwent randomization. So we have 1,175 in the control arm and 1,166 in the intervention arm. Of the control arm, again, 5 were excluded because of one was a prisoner and couldn't consent. Sorry, 2 were prisoners and couldn't consent. Another failed the screening, and 2 of them withdrew consent. So -5 were referred for the stress echo, of which 54 here the stress echo was inconclusive or abandoned. And we ended up with 1,116 who actually had an unconclusive stress echo. This is the control arm, so no AI this side. And then another 8 were lost to follow up. Adjudication not possible because of missing information is 1. And 7 of them withdrew consent, so we can't say much about that. So 1,108 underwent the final adjudication of outcome. And 5.7% total were lost to follow up on this control side. In the intervention side, again, 6 were excluded due to randomization error, a screen fail, and 4 of them withdrew consent. Then 43 of the stress echoes were inconclusive or abandoned, and conclusive final adjudication was 1,105 and 5.2% for loss follow-up. So sort of a balanced loss in follow-up.
But the important point is we are doing diagnostic study. We have positives, we have negatives. The gold standard, which is on top. And we have positive, negative of the new test. The positive, negative of the new test is augmented echo, stress echo. On top is just a plain echo. I mean, the outcome here is whether they had a revascularization or they had MI or what they don't, what most diagnostic studies don't tell you is what happened in people whom the echo could not be interpreted. So, actual fact, instead of 2 by 2 table, it should be 3 by 2. New test, uninterpretable, not done, refused. Sometimes we find that many patients are lost to follow up. What happened? Did they have MI? Did they have revascularization? We don't know. So here the gold standard also there is a large some number which is not there. So in fact, most diagnostic study include a 3 by 3 table. Gold standard positive, gold standard negative, gold standard don't know. New test positive, new test negative, new test don't know. And they will have to tell you how did they adjust for that when calculating sensitivities specifically. Some people will say the gold standard don't know is gold standard negative. Some people will say gold standard don't know is gold standard positive. New test don't know what is it. Is it new test positive? Is it new test negative? You can make any assumption. So that's called sensitivity. So actual diagnosis study, we don't emphasize that. Because large number of people who new test don't know or gold standard don't know, we should do a sensitivity analysis. Okay.
The next question is about blinding and whether the participants, the investigators, and the outcome assessors blinded. And these are the blinding and statistical methods are the questions in the consort checklist which I'll address. So participants were blinded, is what the authors say. The treating clinician was not blinded and instructed to not give the intervention, whether assignment, the allocation not was instructed not to reveal the allocation to anybody else in the pathway. So whether they're referring to a cardiologist or whether they tell the patient, so they were asked not to tell. So, but we don't know how much that blinding actually stuck to. Whether they told the cardiologist, hey, this fellow's AI augmented stress echo was normal or not. Then the adjudication committee showed that within 6 months did somebody have ACS, right? So that team was blinded. Then the statistical methods that they looked at, so primary outcome was difference in the area under ROC. So area under ROC is used for any diagnostic test. So our diagnostic test here becomes the standard decision-making pathway. Can it distinguish between yes or no coronary artery disease? And AI augmented decision pathway, yes or no, can it distinguish between coronary artery disease? Then between subgroups, they use logistic regression. And for they have talked about related but unexpected ACS and follow-up testing, which were our secondary outcomes. They used mixed effects, ordinal logistic regression, and for patient-reported outcomes, the Wilcoxon rank sum test.
So the treating physician, the cardiologist?
Not necessarily. Yeah, not.
The treating physician is not the person who gets the AI augmented.
Is the treating physician is the one who gets the AI. So it's not, I couldn't make out whether the person doing the stress could also be the treating physician, stress for cardiography. I'm not sure whether in UK it's a technician who does it or in any situation the doctor themselves was doing the stress echo and the data, so that's not clear.
Then there was no way the treating physician could have been blind.
There was no way. So there was no way the treating physician could have been blinded because they, them knowing the AI result was sort of the intervention. And but that kind of complicates whether anybody else was blinded or not. Whether if they told the patient that yes, your AI augmented result is suggested coronary artery, the patient is more likely to go for the angio, not be lost to follow. So that is not clear. I mean, they've said the patient is blinded. We don't know in real life how much it worked out. They did change the analysis type for their primary outcome, and it was supposed to be a generalized logistic mixed model with accounting for site as an effect. Then they changed it to the difference in AUROC. So they have said that they did this after discussing with the journal reviewers and the statistical and editorial reviewers from the journal. And they said that the pre-specified primary endpoint was consistent. So using this model or the AUROC, the result was same and it did not alter the result. So they clearly told that even though they changed the method of analysis, the result didn't change. And this is why they have changed their method of analysis. Then we come to whether the randomization worked. So whether the study groups were similar at the start of the RCT, and we look at the baseline characteristics. This is the part of the consort checklist. So the baseline characteristics in terms of gender, age, BMI, race, smoking status, they were all matched. We had almost 50, like a large number of women, which I thought may be different from our population. We may have more men with who are being referred for stress echo and then for the angio. Very few had diabetes, only around 20%, less than 20% actually had diabetes in this group. The use of medications that have cardiovascular medication was similar in both the groups and also other comorbidities. Another thing that is different is the type of stress echo that was done. So I think we mainly use exercise stress echo rather than dobutamine, but here around 74-73% of patients actually underwent dobut stress echo. This is the patient characteristics in terms of the physiology at the time. So heart rate, blood pressure, number of, this is the findings of the stress echo. So this was again matched at baseline. The next question is whether there were any co-interventions. So in addition to our intervention of this AI augmented decision, was there any other difference in treatment in both the groups? So they have said that the standard of care was followed for both the arms, and no other involvement was there in decision making. So other than the result, the study did not ask the physicians to do anything else, but it doesn't say whether, since the physician wasn't blinded, I don't know to what extent this could have been followed. So they don't specify, they do talk about, sorry, in their supplements, they do talk about medicine change. So which patients were not previously on ACE inhibitor and then at 3 months and 6 months, they were now on ACE inhibitors, and those, that data is similar for both the intervention and control. So they have not put in place any specific plan that this should happen to this patient, this should happen to this patient, because it's a real world scenario. But they have looked at whether there was any change in medication for patient in the control and the intervention arm during follow-up. So both of the groups received standard of care as per the local protocol. And I put here also whether the AI report was actually used in the intervention arm or not. So of 22% of the time, the AI report was actually not used, and 6.3% of the time, the AI report was not known whether it was used by the physician or not. So we have control supposed to not use AI augmentation at all. We have intervention where the physician is supposed to have the AI information. Again, I think it's more realistic to have some people don't use the report, some people we don't know if they use the report or not. So only 70% of the 1,000 or 1,600 people, so 1,160 people in the intervention arm, actually we know that they did use this AI generated report in their decision making. Then at the end of the section B, yes,
that's important for everyone to look at. If you're doing a new AI, people may not, the clinician may not have much confidence in the AI. If you look at it, 22% AI was not available. AI report was used within 6 months, we don't know. But the AI result was high, very high chance of coronary is 9 and low in 6. One, we know that, but this is the first time the cardiologist said, no, I don't agree with the AI generation. And the confidence is given at quantile. So most people seem to have the 50.9 is in quantile 4. I don't know what to, they seem to have some confidence in it. So we can also, what do you think about this AI report? You agree, don't agree? So one of us will ask, we can also ask the clinician, what do you think about the report? Do you agree, don't agree? You can also report the statistics.
If you look at the validity of the study now at the end of the first 2 sections, the study population was clearly defined, the outcome was clearly defined, randomization was adequate since we looked at the baseline characteristics which matched, allocation was concealed, the primary care provider could not be blinded, and we don't know whether this affects blinding of the patient and any other physicians in the pathway, and sample size calculation was adequate for the outcomes they intended to look at. So then we go to the next section and look at what the results are.
Now, yes, there could be one situation where from the images, the cardiologist, the person who's giving stress echo from that images would have wanted to refer, but the AI will say low risk of coronary artery disease.
That's his choice. If you go back and you reject it, which I don't agree. The choice of is this augmenting? Give you an idea. Whether you take it or not, it's not like if it says, and
Yes,
you must do, it's your choice.
It's more real world, as in like if you have that information, what happens to patients?
We have the data on whether How many disappeared for the AI?
That was stable.
23% time they said, I don't know.
Use, not use, confidence in the.
The physician wanted to go with the angina because they are consulting, but the AI is saying otherwise. Will the patient going to?
Yes. The AI does not affect the decision making directly. It only gives the physician information of AI report is this.
Okay, that's the part possible that means.
Sorry?
That it should be a negative, but the patient is for the angina. But
Yeah. So, no, so even in that table, I will come to the table again. If the patient was referred, regardless of what the AI, even if the AI said, no, this study is not looking at the AI's accuracy in predicting heart disease or no heart disease. It is looking at what happens if this information is available to the clinician in terms of patient outcome. So the patient, even if the physician thought that I should refer this patient, AI said low probability of coronary artery disease, that will still go to that referral. True positive, that yes, referred, yes, heart disease, that.
Like intention to treat the
Yes. So we look at the results. This is the cast question for that, and which asked whether the effects of intervention were reported comprehensively. So power calculation we already looked at. What outcomes were measured we already looked at in the part of the consort checklist. How were the results expressed? Were the results reported at different follow-ups, which is actually given in the supplement but not in the primary paper. Missing and incomplete data information. Differential dropout we already looked at, that there was more or less similar dropout. Any potential sources of bias identified. The statistical tests we looked at what were the tests used for different outcomes, and p-values reporting, which I'll come to. And this is the consort AI checklist, and in blue here is actually I'll come to this later. I put this in gray because harms comes later. So here we're just looking at outcomes and ancillary analysis. So this is our primary outcome of the area under the receiver operated characteristic curve, and in control arm, the AURC was only 0.55, which was much lower than they expected. They expected 0.8, with a confidence interval from 0.3 to 0.8, not very precise also. And for intervention, it was 0.63, and again, confidence interval 9% from 0.43 to 0.83. So from what I read about how they generated this confidence intervals, they did something like they, from the data set they had, they would take a certain number of results. They would like how we understand confidence intervals as if you did this study 100 times, what the result would range from this to this 95% of the time. So something like that from the same data, they used some function in their software, and they came up with this confidence interval by running the same test multiple times.
Confidence interval calculation be different because AI is like a
No.
like a diagnosis.
When you do otherwise, you can get mean and standard deviation, you know how the confidence interval. But when you do the ROC curve, we have a curve. How do you calculate the confidence interval of that curve? That's the value of this study. But you can also draw a shaded area and say this was the confidence interval for that curve. And those two curves, the confidence interval should not overlap. Then you say the two curves are different. She's saying that there is a statistical technique for generating confidence interval for ROC curves.
So that will be diagnostic.
Like a diagnostic study, but there is nothing to do with AI. How confidence interval is calculated for ROC?
It was something new that they have actually given in detail as to how
So
they.
was there a difference in the curves?
So actually, I the document open. I forgot to put it in the slides. The ROC curves are a little different, but very slightly.
No, the difference is 0.09 area, but it could be minus to plus. So there is no difference in the ROC.
And here they have given a breakdown of how many true positives. So 27 patients in control arm were referred for angio and had required revascularization, whereas 34 of that in intervention. Now we have to remember the denominator, which was not mentioned in the table, which was some 1,100.
From this we can make the 2 by 2 table. No. Total of 27 plus 1050 will be the gold standard.
So hospitals have followed.
34 plus 1037 will be the. No, sorry.
So 27 and 9 will be our test positives, and so out of 36, the AI told, the physician out of these 36 decided to refer 27 patients, and 27 of them had coronary artery disease, 9 of them didn't have. Or if you look at it this way, false negatives. So of the 1,072 patients who were not referred for coronary angio, 22 of them ended up having an MIN, 6 months in the control arm. And here, actually, we can do the calculation. So 22 out of 1027 and 90.
Numbers are given below that.
They've calculated this value. Yeah.
So is it more sensitive or more specific?
It is more specific than it is.
So we use it to rule in disease or rule out disease.
Rule out.
And that's following the negative predictive value.
No, rule in disease. Rule in disease, sorry. Spin and stuff, yes.
So specific, highly specific, if it's positive, it's disease.
Yes.
So.
But a negative does not rule out.
Does not rule out. But it keeps ulta to the negative predictive value. They seem to have got a highly negative predictive value. If you highly sensitive test with negative, you can rule out. Here the sensitivity is low. You are expecting the negative predictive value to be low. And they've got a higher negative predictive value. Specificity is high. You are expecting the positive predictive value to be high, but it doesn't seem to follow. Okay.
I've just put here again what each of the things means. The subgroup analysis. So they looked at, this is the ITT, this is the per protocol analysis, which again did not show a difference between different genders, existence of these were the stratifications if you remember, gender, prior coronary artery disease. Then I'm not sure why they used, I think contrast use was to see whether the stress echo, the quality improves when whether you use a contrast or not. And again, that didn't show a difference. In fact, when they didn't use contrast, control seemed to be better than intervention, but again, the difference is not significant. And it seemed that centers which have a low load, so low volume centers, maybe intervention was better than control, but again, the result is not very precise. So maybe in a high volume center where the person doing the stress echo itself is so good at the stress echo that the intervention doesn't really make a difference. And all the clinician's judgment. It may not be just based on the stress echo.
Into the sensitivity and specificity, as compared to control, the intervention had less specificity, right? And sensitivity was.
But the confidence intervals like overlap also. Like it's difficult to really have a difference, comment on difference between them.
I think this outcome of MI is included in MI.
Any ACS is what they have. This is like based on chart review and any
yeah, stenting also, angioplasty also, or anything is taken up, yes.
These were the secondary analysis. So objective 1 was whether the management was appropriate or not. Objective 2 was whether there were any acute events. And objective 3 was the follow-up testing, such as were the patient sent again for a perfusion scan or exercise tolerance test or a cardiac MRI or a repeat stress echo. So this was not different between the control and intervention. These were a pre-specified secondary analysis. Since non-inferiority was not met, we need not comment about superiority anymore. Another secondary outcome was this is the Seattle Angina questionnaire, where higher is better quality of life, and the patient quality of life baseline. This table they have not mentioned whether the Seattle Angina questionnaire itself also has a quality of life component, and they've also used the EQ5D. But based on the score, I'm guessing this is the EQ5D result, which goes from I think -0.1 to 1, and again higher is better. So there was no difference between quality of life in the intervention and control arms. So the next question in the CAS checklist is about the confidence interval, which we already looked at.
Quality of life is control intervention.
No, that's another thing. Finally, in the end, cost, everything boils down to cost. So both are equal, and one has slightly better quality of life, then it's an intervention. So nowadays, everything apparently becomes policy. If you want to introduce something in policy, it has to make economic sense. And what you can't capture in terms of health, in terms of physical cost, a large area of cost is unmeasurable cost, which is suffering, pain, which is reflected in quality of life. So if you want to change the policy makers might not only capturable cost, you have to show quality of life.
The intervention is not highly decisional. We are better. So even if the report is negative or positive, the physicians will make a decision on whether they got the angiogram or not. So even if it showed better quality of life, there is no logical reason why.
That's just a now current RCT, but all of them will have quality of life as well. 100%. All cardiac trials now have cancer city, KCQA, they have used another one.
Yeah.
CRA. Because that, if you want to change the policy measurement, you show one is cost effective. You have to show that quality of life was measured and at least it will become worse. It is better than it's a big mess. So that's there's no logic. How can just blowing one echo finding change the quality of life? If you didn't measure it, they say it's a study of body mass. We can't change the policy. You didn't check it. You just study for patient important outcome was not patient.
They were, I think, eventually hoping that okay, this will be better, and then we can also show if this patient had less MI or less hospital visits, and that would improve quality of life, but it didn't end up showing a difference.
The expected AOC, their sample size is 0.88 and they expected 0.07. Now that the control is performing so good, can we take that 0.09?
No, so now we as a leader have to understand. They expected the area average of to be 0.88. How come they landed up with 0.55? What is, how come with an expectation? They will argue that from previous studies we got 0.88. In reality, we landed up with this. We have to explain why they got it. Maybe their patients were much sicker than previous studies. Or their patient was much better off than previous studies. Maybe overall their stress echo itself is not a very good. Their quality of stress echo is not at all good. They expected the baseline stress echo without AI to be 0.88 ROC. Maybe we just say, you can say now, but maybe in that particular country, their stress echo is not very good. We can say, but it's not nice for to shoot them. Yeah.
They have said that the referral numbers basically were much lower than expected, and they are attributing it to maybe because new data shows that the medical management may be as good as intervention. So fewer people are being referred for angio, which is why they didn't get a very precise.
This difference was on more were positive.
We think ROC curve is both positive and false negative. The total ROC has curve, one axis is the true positive, other is false positive. There's a combination of both. More for true positive and less false negative. That's why ROC is taken. Instead of just taking sensitivity alone, we can put both into one number. So we are having very less false negative, false positive, and more false true positive.
So can we take the difference as the
Yes, no, the difference should not include zero.
If the confidence interval wasn't crossed.
You can say significant, yes.
but this we can't.
No, because it's minus 2 plus. So there's no difference now.
This difference was on one side.
Then you can say that's different, it is significant.
Even though the control didn't reach 0.8.
That's okay. That's okay.
You just need to show that the intervention performs better than the control.
No, no. All happens, you will say what is the expected value, how much will it change from that? Yes.
The next question in the CAS checklist is whether the benefits of the intervention outweigh the harms and costs. So here, the intervention didn't show any benefit, and obviously it is going to have the cost of running the computer center that does the AI, all the data that has to be transferred. The next question is about harms or unintended effects. So actually, they have not reported. They have talked about related and unrelated ACS here and there, but they have not given any hard data on whether there are any harms or unintended effects. Now, one wouldn't expect harms or unintended effects from the intervention here, which is just the images being sent and coming back, but they're not reported outcomes, other outcomes in the patient at all. And they have not done a cost effectiveness analysis also. The Consort AI extension also talks about, in addition to harm from the intervention, it talks about whether any what were the analysis performance errors, how were they identified, and whether they did an analysis. So the table that I presented earlier about AI report being used or not was one thing. Actually, I didn't see a table. This was being submitted again, but nothing about. We have a number of. Put that here, but I forgot to mention it. Here. Yes, sir. Also in the result page, I had put it, but I forgot to talk about it here. So, AI assessment was analyzed for 24% of the participants in the intervention arm mainly because of quality issues of the image acquisitions. So, that is the only information they've given about quality performance of it.
The AI outcome did make any position of health in the so right, exclude those 43 patients.
No, but for the intention fit analysis, they have used. They have said that they've done an intention fit analysis, but they're not given the numbers.
So we show the flow diagram. Okay.
My transitions are making.
That's okay. See, so they for the intention to be that actually the 24 people who did not, or 24% whom the echo was not available is before randomization. So they have excluded those people. No.
No, sir. This is after randomization.
One side, there was a. Oh, correct. No, see, technical fault. So I don't know, some people are even before itself excluded, some people are after randomization. After randomization, they must have all included in the intention.
They said that they included the.
Okay.
Then, so we saw that they've not spoken much about harms. They've given some data about errors of the AI. The question is whether these results help locally and whether these participants are similar to our POC participants, if there are any differences, do these affect our outcome interpretation, whether the outcomes that they looked at are important for us, and any other outcomes that we would have liked to know, and any limitations of the study. So participants are similar, but we have few diabetics and more women. Differences that could change the outcome. So the way the stress echo was done, so dopamine stress echo versus treadmill, I don't know, we'd have to look at the difference that would make in the discriminatory power of the stress echo itself. And this population maybe had a lesser prevalence of coronary artery disease in general of the referred population. Like of the 1,000 something that were referred, only some 20-30 had coronary artery disease. Whether the outcomes that we looked at are important. So yes, whether the patient requires to go to coronary angio and whether we are able to successfully rule out or remove the population who doesn't need an angio based on this tool would have been an important thing to look at because angio is invasive and expensive. But there are a lot of other outcomes that they didn't look at, such as long-term cardiovascular and other outcomes. So did the patient have a stable coronary artery disease? 6 months, nothing happened, but maybe later something happened in us. Whether our intervention is to pick it up. Other things that they didn't look at harm, such as any contrast reaction, kidney injury, these were not reported. Limitations, they had a lower rate of referrals than expected, which is why they still emphasize AORC. Whether we missed stable CAD, all stress over dopamine, and AI assisted itself was not available for a quarter of the patients in the intervention arm. So whether because of that, it's not able to show the difference that may exist with the question. So these are the questions from the Consort checklist about limitations, generalizability, and interpretation. And the last question is about funding. So the funding is actually, I forgot to put in the slide, but done by the creators of the Echo Pro. They have funded this trial. And I'll just open the articles, so I'll just show the funding here. And so the last question I forgot here. So in the Consort, funding thing is what we usually use in the Consort for RCTs. The new thing here is whether the AI intervention and code can be accessed. Like Sir spoke about what is the code that they use, what is the model that they use. So because it is starting, but I think they have not given us any details. They're just giving us the version. And I wanted to show the. I'll just share this.
It's easier.
It's the
Rapid expedient.
There. No. It should be shared screen. I think I had to.
That one, no? Isn't that appendix B?
Yes, it is this one, yes. Yeah, and page number 5, yeah, 90. Does it work? The number's not in it. 19. No, the number's not entering. That's okay. Yeah, thank you. So this was the ROC curve that they have given.
Screen is shared. Right.
Screen share. So green here is control and blue is intervention. On the x-axis we have the false positive rate and on the y-axis we have the true positive rate. So this is their point estimates of ROC which they have given there. There is a difference, but like we saw earlier, the confidence intervals are overlapping.
So just one point on the ROC curve. When you see an ROC curve just having two lines, that means it's only a 2 by 2 table in effect into an ROC curve. Generally, the new test will have multiple values, and the gold standard should be positive or negative. Then you'll see the true ROC curve with many points on it. But if the new test is only yes or no, and the gold standard is also yes or no, you'll see an ROC curve looking just like this. So you're trying to say that the blue line is better than the green line. The blue line is the one with AI, with green. So how do you know those two lines are different? One is to look at the area. Obviously, the blue one has more area than the green one. But then you must also look at statistically, can I prove it? That's why you must be able to calculate the confidence interval for each curve and then minus it, and then the software will give you a difference in the area under. An area under the curve of 0.5, the test is useless. So, and a close to 0.1 is very good. This is not so great either way. 0.5 and 0.55, 0.55. It's just anything that's almost as good as tossing a coin. If I have angiogram, let me toss a coin. This is slightly better than that. So that's why it's disappointing. 0.88 means it's very good. What they expected the control to be 0.88. So it's really good. But they got 0.57. So we didn't scratch like this. How come it came from? What happened to their trial? What went wrong? Oh, what?
And I trying to show about funding. So this is the I'm sorry. So this was not funded by the creators of the AI tool. This was a award run by this collaborative in partnership with the NHS. So
Can you show us the software on this article?
where they have mentioned
What software? So one big thing I told you when I did the Consort AI, most people don't want to tell you what software they use, what version, is it supervised, unsupervised. They can say use an artificial neural network, use support vector machine, something they should be able to tell you.
they have given a picture of what the software looked like to the end user.
No. What was the underlying method of the AI in that?
They have not disclosed that, sir. We go to the article.
On their website,
The EchoGo Pro's website. I went to the trial, which was the one that looked at the accuracy of the EchoGo Pro and the protocol of this article. Both of them do not give in explicit, but I didn't go to the website of the creators. This is the Echo Pro algorithm, which has been previously published. You can go there if you wish.
Just click on exit. Maybe that will say something about it. Automated image pipeline was developed to extract knowledge extract from the multi-vendor ensemble machine class learner classroom was trained. Okay, so now I tell you there are some methods. One is artificial neural network, support vector machine, random forest. Now they say, why not I combine everything together? It's like a choir. There's pianist, there's guitarist, there's violin. It's called ensemble. Ensemble methods, you combine many methods together. So they have used an ensemble machine classroom. And the end of it will say yes or no. So they're not telling you what is that ensemble made up of, but it's a multiple methods together is called ensemble. Okay. Any questions, guys?